So we're going to talk tonight about eosinophilic esophagitis and all the different angles from which you can approach. So neither of us have any disclosures. We're going to be going over the basics of eosinophilic esophagitis, which I will commonly refer to as EoE. We'll talk about common options, current options for therapy, as well as the treatment options and best practices as they pertain to medications, dilation, and dietary therapy. And then we'll finalize with just some potential future directions that are on the horizon and some take-home points. So let's get into the basics of EoE. First of all, the symptoms particularly are those of esophageal dysfunction. What I mean by that is there is some disturbance in the motility that will manifest with dysphagia, particularly to solid foods, and it is usually on an intermittent basis. And this is due to eosinophilic infiltrates in the esophagus, which over time can lead to fibrosis and potentially strictures in one phenotype, the fibrostenotic type. This is seen in about one case per every 1,000 patients, and the incidence is almost 13 cases per 100,000 people per year. And there might be possible increases related to food processing. This is an increasingly common cause of dysphagia. It is responsible for about half of cases of adults presenting with esophageal food impaction. It's seen in up to 23% of patients who are undergoing endoscopy for dysphagia, and it's seen in 8% of people who are evaluated for the primary indication of reflux. There are some risk factors that appear to be associated with eosinophilic esophagitis. These include environmental allergens, cesarean delivery and prematurity, antibiotic use, and formula feeding as opposed to breastfeeding. As this is an allergic disorder and these tend to cluster together, patients with EoE are more likely to have other allergic conditions, including allergic rhinitis, asthma, eczema, and a variety of food allergies, the more typical hypersensitivity. So just a little bit about the general treatment approaches. Usual first-line treatments include proton pump inhibitors, PPIs, topical swallowed corticosteroids, and dietary elimination, which Nancee will get into a little bit later in the talk. The goal of treatment is to induce histologic remission, which is defined as a reduction in the eosinophil count to below 15 eosinophils per high-powered field. And that's because the diagnostic cutoff for EoE is that you have to have over 15 eosinophils per high power field in at least 2 levels of the esophagus. We also want to achieve endoscopic remission, and we also want patients to feel better, not have issues with dysphagia. So let's talk about the first medication option, which are the PPIs. The overall histologic response rate is thought to be about 40%. Now, initially it was thought that in order to have EoE, you could not have reflux or you could not have GERD. And so patients needed to be treated with a PPI to prove that they didn't have GERD, and then they were more likely to have eosinophilic esophagitis. However, back in around 2011, a Spanish group found that patients who met all the symptomatic, endoscopic, and histologic criteria or findings for EoE, about a third to up to half of patients might respond to PPIs. And when they looked at patients from a pH testing standpoint, only a third of patients actually had a positive pH study, indicating that PPIs could help people who did not have reflux but met all the diagnostic criteria for eosinophilic esophagitis. And it was thought that it might be from a separate mechanism that the PPIs might have an anti-inflammatory effect, even if they did not have reflux. So it then became the standard to treat patients with a PPI to see if they were what we would call PPI responsive esophageal eosinophilia patients. However, in the most recent iterations of the guidelines and consensus statements, PPI is no longer necessary to be tried first if you have a patient who meets all the criteria for EoE. I'd say over the last 10 to 15 years, PPIs have been getting a lot of negative press because there have been studies that have raised safety issues with long-term use of the PPIs. This is a topic for separate discussion, but the reality is that the PPIs are safe for long-term use when you look at high-quality prospective studies on the matter. And so they really can be considered a good treatment option for patients with EoE if they work. Typically, we will start with twice daily dosing. There's no real clear benefit to using the high dose of the PPI, say omeprazole 40 milligrams versus 20 milligrams, but BID dosing does seem to be more effective at inducing histologic remission than just once a day dosing. After 8 weeks of the PPI, patients should undergo repeat endoscopy so that they can be assessed for histologic response, so more biopsies. And if there is both a histologic and symptomatic response, then really you want to try to reduce the dose of the PPI to the lowest that's effective to control symptoms, and using symptoms as a guide for repeating endoscopy to determine if the histologic response has been lost. Now, with regard to topical swallowed steroids, this really has been the mainstay of treatment for EoE, dating back to really when it was first described in adults back in the 1990s. Overall, the histologic response rate is higher than PPIs. It's about 65%. The most common form is the metered dose inhaler form. So instead of inhaling the medication, the patient is instructed to just build up some saliva in his or her mouth and then swallow when the canister is depressed, not breathing in or out so that it doesn't get sucked into the lungs or it doesn't get pushed out through the nares or around the canister. The most common steroid formulation is fluticasone, and the dosing is the 220 microgram actuation per puff, and 2 puffs are swallowed twice a day. It should be instructed to the patient to use the medicine after eating because you want at least 30 minutes of contact time in the esophagus. And so the patient should not have anything to eat or drink for at least 30 minutes afterwards. I typically recommend after breakfast and before going to bed. Another option, although not as commonly used, is beclomethasone, 80 micrograms per puff, again, 2 puffs twice a day. Another option is what's called oral viscous budesonide. So typically what's taken are the budesonide respules that are used for a nebulized solution for asthma. They're broken open and they're mixed with some other medium. Typically we use sucralose, 5 packets, along with 1 milligram of the budesonide to make a viscous slurry. And this is taken twice a day around the same timing, similar to with the inhalers. Other media have been used, such as applesauce or honey, although it's really been more about small studies, particularly in children. And these different steroids seem to have an overall similar rate of symptomatic and histologic improvement. Now, I believe in the next slide here, we talk about some considerations. So I mentioned about the 30 minutes, not having anything to eat or drink, but I do advise my patients to take a little bit of water in their mouth after they've finished using the medication, swish it around, gargle, and then spit it out. And this will help to get rid of the residue in the mouth and maybe even in the pharynx so that it reduces the risk of oral thrush. Even with this, there have been studies that have shown that there are rates of esophageal candidiasis of up to 25%, although patients are asymptomatic when they're found to have this. Typically, patients will be treated with steroids for 8 to 12 weeks, and at that point, you can consider discontinuation of the steroid. However, there is a very high relapse rate. One study had showed that by 9 months, about 90% of patients had relapse of their symptoms related to EoE. But if you think about it, taking a steroid for 2 to 3 months and then having 6 to 9 months of a holiday from the medication and potentially having a holiday from symptoms may not be a bad way to approach this if you do have concerns about long-term corticosteroid use. There are studies, though, to suggest that, especially in adults, there is no adrenal suppression. So this really is a local effect. Now, when might you consider maintenance dosing or prolonged therapy with corticosteroids? Well, if you have patients who relapse quite quickly after the medication is discontinued, or in patients who have significant fibrostenotic disease, so the strictures are quite, I don't want to say debilitating, but patients are quite symptomatic from them. And in an effort to try to minimize ongoing inflammation that can lead to recurrence of the strictures, maintenance steroid dosing might be appropriate. And the last thing I wanted to talk about, at least from an endoscopic standpoint, is the role of dilation of esophageal strictures. So this shouldn't be used on just any patient who has EoE. It's really helpful for those who have fibrostenotic disease, particularly if it's a much more significant narrowing of the lumen, where patients are having dysphagia several times a day or several times a week. This does not treat the underlying inflammation, so it's really only to increase the lumen or the diameter size of the esophagus and improve dysphagia quite quickly. The goal is you want to reach resistance, typically using a balloon, although the bougie dilators can be quite effective as well. And you go up until the point that you encounter significant resistance or blood, indicating that you have created a mucosal tear. Now, I put here that the goal is 15 to 18 millimeter diameter, but you might need multiple sessions to reach that. So if you see a patient who has an esophageal diameter of 12 millimeters because of a stricture, you're probably not going to get them much bigger than, say, 13, 14 millimeters on the first go around. If you try to go for too much in one shot, you're more likely to put them at risk for perforation. But dilation can be considered as monotherapy, but it can also be used in conjunction with other therapies. So I like to think of it as a way to get people out from behind the 8 ball with regard to their symptoms, and then allow for some other type of therapy, whether medication or diet, which Nancee will talk about, to prevent further stricture recurrence.
Thanks, Kevin.
I'll turn it over to you.
So over the past 20 plus years, there's been a lot of research done on the role that diet might be able to play in EoE. So we're going to spend the next couple slides just going in detail about where we're at in terms of diet protocols for EoE. And I always like to start by pointing out that this is not an IgE or histamine-mediated allergy, right? So patients often say, well, shouldn't I go to an allergist? Don't I need to get allergy testing done or food sensitivity panels done? And what we've learned is that this is a different type of response to food. So it's what's called a Th2 response. And this is generated against what's called structurally diverse entities, which can be anything from parasites to venom, to poisons, to benign antigens, such as the ones that we see in food triggers for EoE. And this is different than what we see with a Th1 immune response. And this is really more against like pathogenic viruses and bacteria. So in terms of the different diet options we have for EoE at this point in time, we call them targeted elimination diets, elemental diets, and empiric elimination diets. And we're going to go into detail about each one of those now. So in terms of targeted elimination diets, this is based on avoiding specific foods by using traditional allergy testing. So this may be skin prick testing, atopic patch testing, or what we're used to seeing with blood serum IgE testing. And we've got enough data now to show that this may not be the best approach, right? We just said that this is not an IgE-mediated food allergen, what we're seeing with EoE triggers. So when we look at children, it's a pretty low response rate between patch testing in kids and when we actually figure out what their EoE triggers are. And the same is true in adults, that only about 13% concordance between what we see on skin prick testing and actually identified EoE triggers when they go through a full empiric elimination diet. So at this point in time, the suggested practice is not that we send every patient to an allergist and automatically have them tested for food allergies to look for EoE triggers. Actually, we want to instead use one of the other diet approaches as our first-line treatment for diet options. And of course, allergy testing can be very helpful for patients who have an overall allergic profile. So as Kevin mentioned earlier in the presentation, patients who have EoE may be at higher risk for other food allergies. So we always want to know what those food allergies are, and we can incorporate them into whatever diet therapy we choose to do with our EoE patients. But again, if they don't have that type of history, we don't automatically need to go and have them allergy tested. So elemental diets were really the first way that diets were looked at and researched in EoE patients. And this started in the late 1990s in children, where children were given these elemental formulas. It was usually a powder that was mixed in water, and they may be able to eat a few different foods, things that were considered pretty low risk in terms of producing an allergic style reaction, such as rice. But for the most part, they were put on these elemental formulas for about a 6-week period, and then they were brought back in for an endoscopy with biopsies. And what we found was that it had really good results. So in pediatric populations, we were seeing up to 96% remission histologically speaking. So this is really good. And because it was so good, researchers started to ask the question, could we see the same type of result in adults? And what we found was that the percentages were not quite as high, but they were really good, up to 72%. So you can imagine these are great results, but there's a lot of challenges that come with offering an elemental style diet to our patients. First of all, I can tell you firsthand, these formulas do not taste great. So I've tried most of them. I personally would not want to have to drink them 3 times a day for 6 weeks. I just think that that's not very helpful for quality of life, right? And really, it's more than 6 weeks because that's just the elimination phase. We then are going to send patients through a reintroduction. And since elemental formulas were kind of the first line in diet therapy, we didn't really know how to do a reintroduction phase, and they haven't been studied in the literature. So we don't even really understand the best approach for a reintroduction phase when it comes to an elemental formula. It's probably something similar to what we'll show you we do for the types of diets that we actually use at UCLA with our EoE patients, but there isn't great research on it. And then there's also a high potential for financial burden, especially since insurance doesn't like to cover these types of elemental formulas. So it could end up costing the patient a lot of money. So for that reason, even though, yes, it does have moderate quality evidence, it's not really the first-line diet therapy we choose for our patients. We really want to instead utilize some of the other approaches that have really good evidence to support them. And that's mainly the empiric elimination diets. So given the efficacy of these elemental diets where they were hypoallergenic formulas, researchers started to wonder about diets where the top leading allergens were removed. Would they get the same types of results, but still allow patients to eat in a fairly normal way? So what we started doing was removing the 6 foods that are at the top of the list, which is wheat, dairy, eggs, soy, all nuts, including peanuts, and all fish, including seafood. So sometimes we'll hear it called the 6 food elimination diet, sometimes it's called the 8 food elimination diet. They mean the same thing. And basically what researchers started to do was look at a 6-week elimination phase where all 6 of these foods would be removed for that period of time. And then patients would be given an endoscopy. And with that endoscopy, they would be put through a challenge phase if they were shown to be in remission according to that first endoscopy post the 6-week elimination phase. And we're going to walk you through how that looks in just a few slides. And what they found is that the evidence was very similar to what we were seeing with the elemental diet. It's actually the same percentage, right? 72% remission rates in adults. And as you can imagine, this comes with its own set of challenges, which a diet is not always the funnest thing to adhere to, and it really does require strict compliance from our patients. So one reason why it's important to have a dietitian as part of your care team is part of our job is to make sure that there isn't a reduction to quality of life. So we try and arm the patient with all sorts of grocery lists and meal plans. We give them restaurants that they can go to. We even give them brands that they can just go to the store and purchase or purchase online. Of course, this is going to require several endoscopies because during the challenge phase, we want to bring back one food at a time over a specific period. And then we want to check and see if remission has continued or not. And this helps us to understand which triggers have occurred. So patients are going to have to be able to get out of work and go and get endoscopies. Luckily, we are finding that insurance will, generally speaking, cover for these endoscopies, but it's still quite a commitment on the patient's part. Also, once we figure out what the food triggers are, this will require long-term compliance with the maintenance phase diet, which means we're removing the foods that have been triggering for the patients, have been found to cause a relapse when they reintroduce them. And this could lead to potential deficiencies if the patient isn't followed carefully and if certain protocols aren't put into place, such as possibly taking a multivitamin or calcium supplements, things like that. So once we figured out that the 6-food elimination diet could work just as well as an elemental diet, researchers started to wonder if it was really necessary to get rid of all 6 foods. Could we maybe instead just focus on the top 4 foods that seem to be causing the most problems for our patients when they looked at them in the 6-food elimination phase? And those 4 foods were wheat, dairy, eggs, and soy. So in 2014, there was a great adult trial that was done where they had patients just remove these 4 foods for 6 weeks and then go through a challenge reintroduction phase. And what they found was with that first one, they got 54% remission. And when we've looked at subsequent studies that were done, the pooled evidence is about 47% histological remission in adults. So we do lose some percentage, but we're also saving patients more endoscopies. And so this is actually a good approach because one study looked at what if we took the 4-food elimination diet and the patients who don't respond to it, we can then rescue them with a 6-food elimination diet. So we just add or take away the nuts and the fish and see if we can rescue them that way. And what they found is when they did that, they could get over 90% success. And so this is what ends up being called a step-up approach. And I'm going to show you that in just a second. But really quickly, the challenges are basically the same. We're still asking a patient to adhere to a strict diet. There are still several endoscopies, though less, that they have to be willing to comply with. And then there will be a follow-up diet that will need to be followed long-term in order for them to continue to have remission of their disease. And so this is where we're at in terms of empiric elimination diets, is this step-up approach. And so what they started noticing as research was collected over basically a 20-year period was that the main triggers over and over and over again were wheat and dairy, with dairy being the most significant, that over 70% of patients were testing positive to dairy as one of their triggers, with wheat following behind. And so there was a thought that what if we do a progressive step-up approach where we start patients on just wheat and dairy elimination? And if wheat and dairy elimination is not enough, we can always rescue them by putting them on a 4-food elimination diet. And if that's not enough, we can rescue them by putting them on a 6-food elimination diet. And what we found with the pooled evidence is we get about 43% histologic remission in adults with just a 2-food elimination diet. So that's really only a 5-point or 4-point loss from when we were doing 4-food. And as you can imagine, this could impact the patient less. They only have to remove 2 foods instead of 4. The thing that we've noticed, though, is that for patients who are more inclined towards the 2-food elimination diet, they tend to be less motivated patients, which means that they're more likely to be lost to follow-up. So if they do the 2-food, they go through the first endoscopy, they have remission, but then when we start to bring them back, they have a hard time figuring out what the triggers are, and they have to then go into 4-food and 6-food. I'm sorry, they're not in remission, they have to go into 4-food and 6-food, we're more likely to lose them and they're less likely to follow through. So we really have to be thinking about what is the best approach based on the patient that's sitting in front of us. There are other diet options that are in the works. One of them is this idea that maybe we could just remove dairy and see what happens, since we know that that is the main trigger. This has only been studied in pediatric population at this point in time, and it's only been studied, there's only been one study on it. And they found that somewhere before 43 and 64% of their pediatric patients could get into remission. This has not been done in adults yet, so it's not recommended as the mainstay for dietary intervention. But there's other future diets that are being looked at so that we can try and optimize either how many endoscopies have to be done, or we can have the most effect in terms of response. So a couple of those diets that are being looked at is what's called a 1-to-3 diet, where we look at the number one trigger, which is dairy, and then we move into wheat and eggs, which is basically the number 2 and number 3, to see if we can slow down the number of endoscopies, which it would. In terms of what might get us the best results is to do a 1-4-8 type of diet, where again, we get rid of dairy, and then we could move to a 4-food elimination diet and see what happens. But if we don't get the response that we need, people are starting to wonder if 6-food is really enough. Should we be looking at other potential allergens such as corn, chicken, beef, and pork? And I can tell you that those clinical studies are in the works, and it will be really interesting to see what kind of diet strategy we end up with in the next couple of years. So as you can imagine, there's a lot of pros and cons to working with the empiric elimination diet. We've already mentioned a lot of these. With the pros, it's very effective at maintaining disease remission if a patient is willing to follow the diet and the protocols. It also helps us to find the root cause. So we're not just managing symptoms, but we're actually understanding what is triggering the EoE. It also gives us an intervention for patients who are not interested in medications. And we actually have rates that are as good as PPI therapy, if not better, for getting these patients into remission. But again, the cons we've talked about, they require strict adherence and long compliance. They require a lot of endoscopies in the beginning to figure out what the triggers are. There can be financial burden. One study was looking at how much more it costs a patient to be on a 6-food elimination diet than their normal diet, and it was upwards of $600 a year. There's also a potential loss of quality of life, especially if this is a person who lives in a home where they've already got picky eaters in their family. Maybe they love to dine out or they travel a lot for work. So one thing is making sure we're finding the right patient for the right approach. For diet, we need a motivated patient, someone who probably has a fair amount of education when it comes to working in the kitchen, reading labels, being a little bit savvy when it comes to culinary skills. And again, this is stuff that the dietitian can work with them on. We also want to think about their living situation, if this is actually realistic, what their lifestyle is like, how willing they are to adhere to the diet, and whether or not this is financially feasible for them. So what does this actually look like in practice? So I won't go over this for too long, but we just wanted to show you what do these different phases of the diet actually look like. So as we mentioned in the elimination phase, we basically remove all 6 foods if we're doing a 6-food elimination diet, 4 foods for the 4-food and 2 for the 2, for about 6 weeks, and then we do an endoscopy to see if the patient is in remission. Clearly, if the patient is not in remission after they've been through the 6-week period, either this means that they haven't been following the diet well, and we need to really go back and make sure that they are not accidentally getting exposure to some of the food allergens. It could mean that the diet is just not the right approach for them, or there is some evidence that's showing you may want to keep a patient on the diet 2 weeks longer just to see if we can eke out remission, that it may take 8 weeks in order to get true remission from the diet. If a patient is in remission, then we can actually move them forward into the endoscopies phase, which I'll show you in just a second. Another option is, remember that we can do a step-up approach. So you can start with a 2-food elimination diet, move to a 4-food elimination diet, and then finally to a 6-food. So part of the job of the dietitian is to make sure patients understand all of the different hidden sources of these different food allergens that could be showing up in their diet. Not only do we want to show them that marinades can have hidden milk in them, or processed meats can have added dairy products, but we want to find them alternative products, because if they love to eat turkey sandwiches every day, we want to make sure that we find them safe bread, safe condiments, as well as safe meats that they can use. We also want them to understand that just because something has soy in it does not mean it's automatically off limits. So things like soy lecithin are actually allowed in this diet. It's just like we also don't need the diet to be on a gluten-free diet. They just need to be removing wheat. They don't have to remove all of the different gluten-containing grains. And same with the nuts and fish. So we just really go over pretty thoroughly. I think our patients nowadays are getting a packet that's about 10 to 15 pages long that really includes long lists of all the foods they're allowed to have, with lots of different brands that they have options for. With the challenge phase, this is where things get interesting. So what we do is we have a patient bring back 2 foods at a time over a 2-week period each for the least restrictive food. So this means we're not doing this for dairy and wheat. With dairy and wheat, we bring 1 food back at a time over a 2-week period, because we know that the likelihood of reaction is high with those. We also look for symptoms. So even though we know symptoms are not correlated very well with what's happening endoscopically and histologically in our patients, if a patient starts to have symptoms before that 2-week period is over, we may decide that they need to come in for an endoscopy sooner, or we may need to take a break and then kind of come back once symptoms have resolved. So in terms of the challenge phase, we start with the least restrictive foods. So in a 4-food elimination diet, we would do soy and eggs. In a 6-food elimination diet, we would do fish and nuts, and then move to soy and eggs. And we always want to make sure that the patient is choosing a very pure form of the food. So we don't want it to have multiple allergens. So for instance, if a patient was to use a soy sauce, we'd want them to go for a wheat-free, gluten-free tamari, not for a regular soy sauce, as that would have 2 allergens. It would have soy and wheat in it. The same is true when we look at wheat and dairy products, which is the last phase of our challenge phase. We want to make sure that there's no other hidden allergens. We also want to make sure that we're giving patients the exact doses that we want them to take every single day. So for instance, if they're going to be doing nuts, we want them to do 20 nuts per day, or 1 tablespoon of a nut butter. So we like to give them as many specifics as possible so that the likelihood of success is high. So at UCLA, we wanted to show you kind of what our algorithm looks like, and we decided to use the 6-food elimination diet so that you would have an idea of a patient who was put on this diet, what it would look like to take them from start to finish. So from elimination phase through the challenge phase and then into maintenance. So as we said, we would start the patient on a 6-week elimination diet, and then we would do an endoscopy, and hopefully we find that they're in remission. If they're in remission, we can add in fish or seafood for 2 weeks. And if there are no symptoms, then we can have them add in nuts for 2 weeks. And then we move on to the next endoscopy. And as you can imagine, there could be 2 possible scenarios here. So if they end up having a reaction, it means that we would want to remove nuts for 6 weeks and then do another endoscopy. If remission occurs, we know that nuts is a trigger, and we can move on to the next set, which is to add in soy. But if there is no remission, then we know that the trigger must be the fish or the seafood. So we want that removed. The patient is welcome to bring back nuts, because that's no longer a suspect as a trigger. And we would then move on to the soy, which is the next step. If a patient, however, continues to stay in remission, this is great news. It means that fish and seafood are not issues for them, nuts are not issues for them, and we can move forward by adding in soy for 2 weeks. And if no symptoms at that point in time, we can add in eggs for 2 weeks. And again, we have the same scenario where we would do another endoscopy, and we have 2 options again. So if the patient has a reaction, they would remove soy for 6 weeks, have another endoscopy. And if remission occurs, we know that that trigger was soy. They would leave that out of the diet and move on to wheat for 2 weeks. However, if no remission was achieved, then the trigger must be eggs. We have them remove eggs. They can bring back soy now, because we know that's not a trigger, and they can add wheat in for 2 weeks. So this is the least restrictive part. We then move into what we do with wheat and with dairy, where we really want patients to be doing them one at a time. So we have them move into the wheat reintroduction. So they bring wheat back into their diet if they're in remission, and they do that for 2 weeks and have another endoscopy. If they have a reaction, we know wheat is a trigger, they have to remove it, and they can bring in dairy. If, however, remission is achieved, it means wheat is not a problem, they add in dairy, and we do the endoscopy to see if dairy is a trigger. So I know when we look at it all at once, it looks a little bit confusing and convoluted, but hopefully walking through it step by step, it makes it pretty reasonable to do this with a patient once, right? The goal is that we do it once, we do it right, we figure out what their triggers are, and we don't have to put them through this process again. So once we get them through that process, we're now what's called the maintenance phase, which means that once we figured out what their trigger foods are, we can remove those offending agents for the long term and help them find alternative products that will work for them. We also can bring back into the diet all of the foods that were found not to be triggering. We want to make sure that there's really good adequacy and balance in their diet, as well as what we call food quality of life. So if some of their favorite foods, like let's say that dairy turns out to be a trigger and cheese was their favorite food, we want to make sure we find them some good alternative brands so that they can still have that food in their diet, but it's no longer in an offending or triggering manner. We also want to look for any possible deficiencies that might come up if a whole food category has to be removed, which may include giving them a well-rounded multivitamin. And of course, we want them to continue to follow up with their gastroenterologist.
All right, thank you, Nancee. So now that we've heard about medications and we've heard about diet, now we'll just talk briefly about medications and diet. So there have been some studies, mainly in the pediatric population, looking at concomitant use of proton pump inhibitors as well as dietary intervention. And in this pediatric population, we found that there was almost double the remission rate, histologic remission rate, among those who took a PPI and were on the 4-food elimination diet versus the PPI alone. And in another study that looked at PPI with milk elimination, there was a 61% histologic remission, almost about 2.5 times the remission rate compared to just dairy-free diet alone. So it raises the question, is there some synergistic effect between diet and PPI therapy? And the reality is we don't know if that's indeed true or what the mechanism would be. There have not been studies looking specifically at steroid intervention along with dietary changes, although that would be another area of research. So just a few things that I wanted to bring up that are on the horizon. So there is a budesonide oral suspension that is already essentially pre-made and does not need to be compounded at home by the patient. It would be the first FDA-approved treatment for EoE, and that is under FDA review right now. In terms of diagnostic means, there is the cytosponge, which has been looked at for assessing for Barrett's esophagus as a screening tool. And this has been looked at in EoE, and it does seem to correlate fairly well in terms of eosinophil counts and degree of inflammation. However, there might be some limitations with this, particularly in patients who have significant fibrostenotic disease for assessing remission rate. Also, there have been a number of monoclonal antibodies that are being assessed, including IL-4, 13, 5, and also IgE. There have been phase 2 studies, particularly with regard to IL-4 and IL-13, that have shown some promise. However, because there has not been enough evaluation into this right now, AGA guidelines recommend that really this should only be considered in the context of clinical trials. In terms of some other potential diagnostic options down the road, there has been looking into food-specific IgG4 levels. There is this novel allergen-specific signature testing using lymphocyte proliferation assays and esophageal IgG4 levels. The accuracy rate seems to be not too bad, 53 to 75%, And with pilot testing on this, they found that only 2 to 3 triggers needed to be eliminated in order to identify the trigger. However, the histologic response rate using this food-specific IgG4 as the guide really was only 25%. There's also the concept of an esophageal prick test as opposed to a skin prick test, where allergen extracts are injected endoscopically into the esophageal mucosa. And they have found that there are acute and delayed responses seen in patients with EoE, but not with controls. So this might be something on the horizon to help better identify what food trigger or triggers might be causing a patient's EoE symptoms. So just to summarize with some takeaways, and then we'll open for questions. Eosinophilic esophagitis is not a typical food allergy. And also, it's not that what the patient gets stuck in their esophagus that's usually what turns out to be the trigger. There really does need to be individualization with regard to how you approach treating EoE. You need to base this on patient factors as well as preferences for their goals of therapy. And food elimination protocols have really been shown to be an effective lifestyle-based means to treat eosinophilic esophagitis. Just have to keep in mind that you need to have these patients undergo repeat EGDs in order to objectively determine if there has been a response. And I hope that Nancee has impressed upon you why having a qualified dietitian to provide guidance is really the best way to optimize the likelihood of success with this intervention. With that, I think we'd like to thank you for your attention.